call and mention one of your colleagues' names for them to come in and help. Are you okay with that? Sakina,
Yes,
are you okay with that?
Yes, please.
All right. So now, all right. Thank you very much. More terminologies. In asthma, we have a term called asthma phenotypes. Asthma phenotypes. What do we mean by phenotypes? Phenotypes, when you are talking about sickling and those things, genetics, that is when we mention phenotypes. But in asthma too, we are talking about phenotypes. So what do you mean by asthma phenotypes? These are clusters, recognizable clusters of one, patient demographics, clinical and or pathophysiological characteristics. So it involves a combination of patient demographics, patient clinical characteristics, and pathophysiological characteristics common with patients. And we can use this one to classify asthma in patients. So this is what we mean by asthma phenotypes, a recognizable clusters of characteristics, including demographics, clinical characteristics, and pathophysiologies. In terms or by way of asthma phenotypes, we have the following. The first one is the so-called allergic asthma. So somebody's asthma is described as being allergic asthma, allergy in nature. So allergy, what goes with allergy? So this is normally what happens when you are young. So the so-called atopic type, it normally starts from childhood. And normally the patient would have a history or a family history of an allergic disease. In these individuals, you realize that the asthma begins in childhood, and that person will have exclusively some history of allergic disease, or in that person's family, there is a known history of some allergic condition, be it like eczema or rhinitis. In these individuals, if you examine in these individuals, if you examine their sputum, you realize that you have evidence of the allergy. So normally you have eosinophils in their sputum. You analyze their sputum and you have high levels of eosinophils in the regions of 150 cells per microliter, 300, 400 and above. Hardly would you get below 100 cells per microliter. And that shows that inflammation is ongoing. Due to this, these individuals are responsive to inhalational corticosteroids. Yes. Because there is inflammation, and inhalational corticosteroids are anti-inflammatory in nature. So they respond well to ICS therapy. So note this, it begins during childhood, history of allergy, either peculiar with the patient or his or her family line. You have evidence of inflammation if you do sputum analysis, eosinophilia. And of course, they normally respond well to corticosteroids, the inhalational ones. Any queries? So that is the first phenotype, allergic asthma. Then the non-allergic asthma, of course, as the name suggests, is the direct opposite of the allergic one. So you don't expect eosinophils that much, but rather neutrophils. Then you are thinking about more of infectious, bacterial infections in a way. Key thing is that they respond lesser to ICS because it is not an extreme inflammation. The inflammation is there, but you are not going to have high eosinophilia, and therefore they will not respond to the same extent to ICS as those with allergic asthma would do. Then we have the cough variants or cough predominant. In these individuals, cough may be the only sign that you can determine in them. But of course, in latter days of the conditions, the condition becomes worse, and issues like wheezing, may step in, and bronchoconstriction occur, such that these individuals will respond well to bronchodilators. However, they also respond well to ICS therapy. So now we have core variants, also known as cough predominant, and allergic asthma. These two phenotypes, they respond well to ICS therapy. Non-allergic asthma, they respond to ICS therapy. Non-allergic asthma, they respond, but to a lesser extent. We are not saying that they don't respond at all. They respond to a lesser extent. Then adult onset, another phenotype. So this is the type where it will never happen in childhood. The first time that the person is experiencing anything like asthma is in his or her adulthood. Never, nothing at all, nothing. So these individuals will respond to ICS, but only at higher doses, or at times they may not respond. Their treatment may be relatively refractory to ICS therapy. A subset of this is when you are adults, you are working. Then we can say that you could have occupational asthma. So asthma due to exposures at work. It is only during your adulthood and you are working. Then upon some exposure to certain trigger factors, you will get asthma symptoms. Then asthma with persistent airflow limitations. This time you are in huge trouble. And this will normally occur with long-standing, poorly managed asthma. Persistent airflow limitations. This normally occurs due to when the airway undergoes remodeling. And therefore, it is very difficult for you to even respond to therapy. At times, it may even reach a level where it almost gets into the stage of almost like COPD. It is not fully reversible because of airway remodeling. You have destroyed the airway architecture. Then asthma due to obesity. A lot of weight, putting more pressure on the lungs. And of course, the fatty tissues releasing pro-inflammatory condition called asthma. These exclusively happens in obese individuals. And asthma is an inflammatory condition. So this exclusively happens in obese individuals. And the risk is that you being obese will cause central abdomen that can even affect your thoracic region. And of course, the bad fat in the abdomen also releases cytokines that may contribute to the inflammatory condition called asthma. These are the phenotypes according to clinical characteristics, demographics, and pathophysiologies. You can have obesity, you can have asthma with persistent airflow, you can have adult onset, non-allergic, allergic, and cough variants through cough predominant asthma. These are the main phenotypes if you are talking about asthma. Any queries? All right. Now, let's see how we can also classify asthma asthma based on disease severity. Again, later on, we will discuss terminologies like forced expiratory volume in 1 second and peak expiratory flow rate. But Sakina, I understand these terms you are familiar with. I'm not asking you to explain what forced expiratory volume in 1 second is, or how it is done, or what peak expiratory flow rate is. But I want to confirm if you are familiar with them. Please, class captain and your group. I know you know, but tell me, confirm it. Because I'm using them here to explain severity classification. Class captain, Sakina, the rest of the class, please. Are you familiar with these ones? FUV subscription.
Yes.
Yes,
Hello?
yes, please.
Yes.
Yes, please.
Yes. I would
Yes,
be surprised if you said no. Because how? Because I've been in several of your presentations and you guys have been talking about it, explaining it with ease. All right. So now, in terms of classification based on severity, somebody can present or can have intermittent asthma. Intermittent. So what do we mean, or when do we say that somebody's asthma is intermittent? So we can confirm that based on the frequency of the symptoms. Then the lung function test shows how capable the lungs are, how well the lungs are functioning. So parameters that we use to assess the patient's lung function can be used to determine the class in terms of severity and how often the symptoms occur, especially the pattern, daytime and nighttime. So let's look at intermittent asthma. So in terms of the pattern of symptoms occurrence, your asthma is intermittent if you have less than one time occurrence of daytime symptoms per week.
Which level?
So within a week, you don't have even one symptoms. No, it may take more than a week before you get one symptom or the signs and symptoms will occur daytime. Or nighttime, you have equal to or less than one occurrence of nighttime symptoms per month. M stands for month, WK stands for week. So that is it in terms of frequency of symptoms occurrence. Intermittent daytime, less than one per week. Nighttime, equal to or less than twice per month. Then your lung function test is on point. Here, your forced expiratory volume in 1 second is equal to or greater than 80%, which is perfect. And then your peak expiratory flow variability is less than 20%, another perfect. Once the variability is equal to or more than 20%, then it is suggestive of asthma, and in fact, severe forms of asthma. You are getting there. You are getting to almost severe forms. So if you have these features, then your asthma is intermittent. It doesn't occur. The pattern is not quite often. You have nighttime symptoms once or twice maximum within a month, a whole month. And nighttime symptoms within a week, you are not even getting one time. Daytime, you are not getting one. It may take more than a week for you to get one-time symptoms, daytime. Then it becomes mild persistent. Mild persistent is worse than intermittent. So you can see that all the parameters are getting worse. So daytime, now you have one or more symptoms occurrence per week. The nighttime symptoms is now more than twice a month. However, your first expiratory volume in 1 second is still normal, but your variability in peak expiratory flow rate is beginning to get worse, 20 to 30%. Then moderate persistent. Now it's becoming worse. Daytime symptoms every day. Nighttime symptoms, previously it used to be twice per month. Now it is at least one per week. Then forced expiratory volume in 1 second is declining 60 to 80%. Variability in your peak expiratory flow rate is getting worse, greater than 30%. You are not consistent at all. Then it's severe when every day you are getting the problems, nighttime problems, frequent every now and then. It's waking you up, you are struggling, you can't sleep. Your forced expiratory volume in 1 second is really bad, now less than 60, which is poor. And again, of course, your variability in peak expiratory flow rate is greater than 30%. So in summary, it shows that from intermittent through persistent, mild to moderate to the highest severity, the parameters only get worse. And based on that, we can use it to classify somebody's asthma. And this is based on disease severity. We are using the pattern of symptoms occurrence and lung function test to do this classifications. Any queries? All right. So let's look at the epidemiology. Asthma is common, especially in industrial areas where they are exposed to many trigger factors. Say about 300 million people, the whole world, do have asthma. But it varies, of course. Some countries do have higher prevalence rates than others. Unfortunately, 80% of asthma-related deaths occur in lower income countries. So Ghana, we are part. The WHO estimates the incidence of asthma in Ghana as 1.5 per 1,000 per year. That is the incidence rate of asthma as estimated by the WHO. These are common trigger factors, meaning if you are an asthmatic and you are exposed to some of these factors, it may or it can cause exacerbations. You may end up at the emergency unit because of exposure to some of these factors. Exercise. So exercise can dry your airways, and this can lead to bronchial smooth muscles contractions, and therefore bronchoconstriction. By this, exercise can induce asthma. This is how come some athletes who are asthmatics will use bronchodilators prior to the exercise so that it relaxes the smooth muscles to avoid bronchoconstriction. If you're unlucky and you get respiratory infections, unfortunately, even from viruses, bacteria, whatever, of course, these agents can trigger inflammatory attacks, and this can cause the exacerbations of asthma. Allergens, pollen grains, and what have you. These can activate and cause degranulation of mast cells and cause the release of inflammatory mediators, as well as other agents like histamine and the likes, and trigger asthma exacerbations. Even your diet may contain certain excipients or additives. And if you are allergic to those additives, they can also act as trigger factors. Of course, well established drugs with established mechanisms of asthma exacerbation induction, ranging from aspirin to NSAIDs and even beta adrenoceptor agonists, especially the non-selectives, are known to contribute to asthma exacerbations. Environmental factors. Here again, this guy is here. Tobacco, and for that matter, nicotine, causing a lot of irritations and bronchoconstrictions, and of course, inflammations, air pollutants, industrial areas, a lot of smoke, dark ones coming out that can cause airway irritations. Your emotions, if you are stressed, this can trigger parasympathetic activations. Emotional stress can do that. And you know, parasympathetic activation will lead to bronchoconstriction. So don't stress yourself too much emotionally. It can trigger asthma. All right. Any queries? Any queries? All right. So let's discuss risk factors. Some are modifiable, some are unfortunately not modifiable. So the environmental factors, of course, they are modifiable. Once, as Sakina said, if you avoid them, then you are not getting problems from them. Obesity is modifiable and can be managed. As I said, the weight that you have around the abdomen can put more pressure on the chest, and the fat within the abdomen to release pro-inflammatory mediators, as discussed in diabetes. The mechanism of resistance, insulin resistance in diabetes, stems from this same thing. Bad fats within the abdomen releasing cytokines that can cause a lot of problems, including asthma. Then smoking, of course. The nicotine can cause the recruitment of inflammatory cells, causes oxidative stress, irritation, and so on and so forth. Viral infections can cause inflammation. Bacterial infections can cause inflammation. Occupational exposure, you are in trouble. Socioeconomic status, you live in a place where the environment is very bad, a lot of dust, a lot of smoke, you are in trouble. As stated earlier, now socioeconomic status is becoming risk factors to almost every condition. If you are poor, you are in trouble. You are always at risk of any condition at all. Non-modifiable ones, genetics, if it's within your family line, there is nothing you can do. You can't modify it. You can't modify it. And then the hygiene hypothesis as an example. You are born in London, very neat. Somebody's mic is on, please mute it. The one walking. All right. So hygiene hypothesis, a female holding you, that is not your portion. You are always exposed to clean environment. The day that you come to Africa and you are exposed to dirty environment, you will see your race could predispose you. Blacks, we are in trouble. Perinatal factors. Now, there is evidence that low birth weight, wheezing, low birth weight, that's odds ratio of 1.43, 43% chance of getting recurrent wheeze if you are born with low birth weight compared with somebody with normal birth weight. If you are not lucky, then in addition to low birth weight, you are born prematurely, like prematurity birth. It even increases the odds from 43% to 77% in terms of recurrent wheezing. this correlates well. So those who are born with low birth weight and are also premature, most of them, they have this odds ratio, very high chance of developing recurrent wheezing if you are born with low birth weight or low birth weight plus prematurity. Any queries? Any queries? All right, let's look at the pathophysiology. Very brief. It's all about inflammation. Inflammation. So once you get exposed to the trigger factor, you respond. Your immunity, of course, will respond. And immunoglobulin E antibodies are normally the ones that are most important. If you are lucky and the immune response is acute, then, of course, we all know that acute inflammation is something that protects you from invaders, maybe the viruses, other pathogens. But in asthma, unfortunately, in most cases, the inflammatory response doesn't remain acute, but it stays and it becomes chronic. That is what caused the damage. Acute inflammation would have been brief and protective as it does. But in asthma, the inflammation stays, becomes chronic, and the end result is injury to the airways and the resultant airway remodeling. The resultant airway remodeling. This is what goes on that is very bad and unfortunate in asthma. In fact, it is known that disease severity correlates with very strong inflammatory response. So the higher the inflammatory response, the higher the clinical severity. And in fact, various inflammatory cells within the airways are involved in this distraction. So in summary, you have an exposure to a trigger factor. It can be anything at all. Then inflammation occurs that leads to airway obstruction. You are producing a lot of mucus. There is bronchoconstriction. Your airway becomes hyper-responsive. And that is what will give rise to the clinical symptoms of wheezing, cough, chest tightness, breathlessness, sweating, and on and on and on. So key inflammatory cytokines involved include interleukin 4, 5, and 13. 4 is normally responsible for the airway smooth muscle spasm. So you can see a normal airway, very patent, nice hole within it. But in the presence of interleukin 4, there is smooth muscle spasm. You can see that the patency is no more because of the contractions. The airway is closed. Interleukin 5 will lead to the production of high eosinophils. So eosinophilic inflammation leading to the release of more distraction agents. Then you have interleukin 13 that is responsible for mucus hypersecretion and goblet cell hyperplasia. So goblet cells will become bigger in size and there is high mucus secretion. Mucus will plug the airways. Goblet cells becoming bigger will also further reduce the lumen of the airways. Then F criteria are all based on the 2020. As I said, by all means, new guidelines will come in. So when it comes, we need to check the new things, the update, what is new, and then we add it to the 2025. Any queries? If not, we meet same time next week. Remember, this is a combined class, so it's for both the in-person and online. Online group, we are meeting tomorrow for meningitis, our second infectious disease. All right. Class captains, any announcement?
No, please, you stated it clearly for the online class, so it's fine.
Okay. Then tomorrow, I'm sure you are still meeting Dr. Ishak. So don't forget, 3 p.m. to 6 p.m. at your usual meeting place. All right. Thank you very much.
Salah holiday.